We are good to go.
Namaste, everyone. First things first. So let's have the lighting of the lamp and pray to the Almighty that everybody is in the best of health for a long, long time to come. Please.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपो हरतु मे पापं सन्ध्यादीपनमोऽस्तु ते
Sheetal, can we have the next video, please? You know, when many people ask me, who is the chief, who is the guest, who is the very important person, I said, just about everybody whom you can see on the screen. So thank you very, very much for joining us. You are truly very, very important to us and the girls and women of this great country. Yeah. Sheetal?
Nishad, play the video.
Welcome to Artist for Her. Artist focuses on activities that will contribute towards the Sustainable Development Goals as outlined by the United Nations. We are a group of expert healthcare professional, leaders of professional organizations, national and international, key opinion makers, researchers and academicians, leading clinicians in practice. Artist for Her has adopted an ambitious vision 2022, which has been categorized under 5 verticals A, B, C, D, E, namely adolescence care and anemia control, building contraceptive choice, cervical cancer and vaccine, diabetes, emergency care during childbirth. Artist supports programs that are built around A, R, T, advocacy, research, training. Advocacy. To reach patients and professionals with the right healthcare messages on the relevant channels. Build advocacy to address health, social and economic challenges. Empower women and youth. Research. Research in Indian context to see what works for us in this complex and diverse country with unique socio-economic challenges. Improve access to innovative and equitable healthcare solutions. Our complex social, political and economic dynamic makes India a truly unique nation. Training. Working with steadfast dedication towards building skilled healthcare workforce and enabling pertinent policy change especially in the sector of women's healthcare. Artist has also laid emphasis on lending emergency care and medical aid to women during childbirth. Artist has closely worked with the national body FOGSI and international body FIGO. The skill transfer by Artist is brought to scale through a cost-effective methodology on digital platform. Our vision is to train 1 million healthcare providers to reach every woman and girl in our country. Please join us and visit the website at www.artistforher.com.
A very good evening to all the faculty, the delegates, and every one of you present here. I, Dr. Purne Narayanan, on behalf of Artist, which expands as the Asian Research and Training Institute for Skill Transfer, would like to connect and collaborate with you all by welcoming you to yet another webinar in the SHAPATH series. To achieve the zenith of women's healthcare, we believe in the 3-pronged approach of advocacy, research, and training. And SHAPATH is our 1,000-day journey towards Anemia Mukt Bharat, a pledge, a promise to get all our girls and women in the pink of health, literally and figuratively. In August 2021, in the very first of this webinar series, Dr. Hema Divakar was in conversation with Dr. Uday Thanawala on the resolve to make India anemia-free, followed by a panel discussion on bleeding in pregnancy. Dr. Chinmayi Ratha gave us a brilliant talk on the various placental positions on ultrasound in September, followed by a discussion on accidental hemorrhage. October saw a detailed insight into the diagnosis and prognosis of fetal anemia by Dr. Bijoy Balakrishna, followed by a panel discussion on the management of DIC and Sheehan's syndrome. In November last year, Dr. Niharika Malhotra opened our minds to fresh ideas and thinking on how to achieve BARA, a hemoglobin of more than 12 gram%. This was followed by a panel discussion on adolescent menorrhagia. A couple of months ago, Dr. Parag Binewale spoke to us about anemia not responding to parenteral iron, and we also had a panel discussion on the management of fetal growth restriction. In addition to the webinars, on the 12th of every month, we hold radio programs wherein our experts tell the whole country about the importance of achieving a hemoglobin of more than 12 gram%. Janani Swasthya Rast, a new initiative to reach healthcare to the doorstep, is being launched by artists in partnership with IHW Council. We will be back with more information on Shapath on the wheels. We have been training our nursing staff on how to test, talk, and treat anemia in all the women they encounter. We believe in starting early and young and creating awareness in schools and colleges through health and hygiene projects will help us to go a long way to achieve our goal. So today, we come to the 6th in the series of webinars. In session 1, Dr. Lakshmi Srikhande will give us the updates on iron deficiency anemia in pregnancy. Dr. Hema Divakar will be chairing this session. This will be followed by a case-based panel discussion on coagulopathies in PPH. Dr. Hema Divakar is the CEO and chairman, artist. She's the medical director, Divakar Specialty Hospital. She's the dean, KCOG, past president of FOXI, 2013, vice chair for FIGO PNCD committee from 2015 till date, and she has been elected as chair of Well Women Healthcare at FIGO. She is the recipient of a number of awards and recognitions, which include the FIGO Women Achievers Award 2015 and Global Asian of the Year 2018. Dr. Lakshmi Srikhande is the medical director, Srikhande Fertility Clinic, Nagpur, Maharashtra. She's the chairperson-elect, ICOG, National Corresponding Editor, Journal of OBGYN of India, JOGI, National Corresponding Secretary, Association of Medical Women, India, founder patron and president, ISOBAB Vidarbha chapter 2019 to 2021. She was the senior vice president, FOXI 2012, president Menopause Society, Nagpur 2016 to 18, president Nagpur OBGYN Society 2005 to 2006. She too is the recipient of a number of awards, including the Bharat Excellence Award for Women's Health. Over to Dr. Lakshmi Srikhande.
Emma, I have to start directly? Yeah. Yeah.
Yes, Lakshmi. We will come back to the conversational discussion at the end of your presentation, right?
Yeah. So my
Thank you for
slides are
being-
visible. I am audible.
Yes, Lakshmi.
Yes.
Perfect. Perfect.
So very good evening to one and all. And I must appreciate the great initiative taken by artist for her and Emcure. And I like the caption Shapath very much. So very good work you are doing, Hema. Keep it up. Topic of my deliberation today is update on iron deficiency anemia in pregnancy. So first let us see what is the burden of this disease worldwide. WHO has given statistics that more than a quarter of the world's population is anemic. And in India, up to 88% of pregnant and 74% of non-pregnant women, they have iron deficiency anemia. And friends, iron deficiency anemia is only the tip of the iceberg. That is, only 1/8 is visible, and the unseen under the sea, which is not visible to us, is 7/8 of the problem. Remember, iron deficiency is 4 times more common than iron deficiency anemia, and iron deficiency is defined as serum ferritin less than 12. In iron deficiency, hemoglobin can be normal, but there is a compromised supply of iron to tissues, there is decreased or depleted iron stores, and the consequences of iron deficiency are similar to iron deficiency anemia. So now coming to my topic, that is iron deficiency in pregnancy. As you all can see in this slide, that anemia is a major killer disease in India. 1/5 of the maternal death is directly related to anemia. You can see in antenatal, it is 50.13%, and in lactating woman, the incidence is 58%. And why we do have such high prevalence of iron deficiency and iron deficiency anemia in India? Because we have early onset of childbearing, because of early marriages, we have high parity and short interpregnancy interval, poor eating habits, hookworm infestation, H. pylori infection, malaria, and hemoglobinopathies all contribute to high prevalence in India. Anemia in pregnancy can be physiological, can be pathological, and pathological ones can be nutritional, hemorrhagic, or hemolytic. Now let us first see what is physiological anemia in pregnancy. We all know during pregnancy, there is a disproportionate increase in plasma volume, RBC volume, and hemoglobin mass. There is all time a physiological iron deficiency state during pregnancy, and the above two factors result in less hemoglobin concentration in pregnancy, which is called as physiological anemia of pregnancy. So these are the common anemias in pregnancy, and we all know out of all these anemias, iron deficiency anemia is the commonest anemia in pregnancy. It is the most common nutritional anemia. Indian women are anemic to start with because of various reasons, and this is the vicious circle which takes place in the pregnancy. There is poverty, malnutrition, early marriages, poor spacing leads to anemic mothers, which leads to anemic infants, parasitic infections, again leads to malnutrition, and this vicious cycle goes on and on. And thus, an Indian girl invariably enters her reproductive career in an iron depleted state. So what is the pathophysiology of iron deficiency anemia? Iron stores in the initial stages are reduced without reducing the serum iron levels, and it can be assessed with serum ferritin measurement. Iron stores can be depleted without causing anemia. Once iron stores are depleted, there still is adequate iron from daily RBC turnover for hemoglobin synthesis. In the second stage, the iron deficiency occurs, hemoglobin falls just above the lower limit of normal. And in the third stage, which is considered as iron deficiency anemia, and it occurs because of hemoglobin fall to less than normal values. So coming to the definition of anemia in pregnancy, first trimester, hemoglobin less than 11, second trimester, less than 10.5, third trimester, less than 10.5, and postpartum, less than 10 is considered as anemia in pregnancy. ICMR has graded anemia into mild, moderate, severe, and very severe. Mild is when hemoglobin is between 10 to 10.9. moderate when hemoglobin is between 7 to 9.9, severe when it is less than 7, and very severe when hemoglobin is less than 4. Symptoms of anemia, everyone is very well versed with it. I want to brief why we are so much concerned about anemia in pregnancy. Just have a look what havoc it can create as far as the maternal complications are concerned. In the antepartum period, this can lead to preeclampsia, APH, abruptio, intercurrent infections, PPROM, preterm labor, and cardiac failure. Intrapartum, this can lead to prolonged labor, PPH, labor dystocia, increased incidence of operative delivery, and cardiac failure. In the postpartum period, it can contribute to puerperal sepsis, subinvolution, failed lactation, thromboembolism, and delayed wound healing. This is not enough. Anemia can also create havoc as far as fetal complications are concerned. So what it can cause in perinatal period is that it can lead to IUGR, low birth weight, neonatal anemia, neonatal infections, and preterm birth. And long term, this child may suffer from delayed cognitive function. That is why we all have to work and join hands to fight anemia during pregnancy. Now, who should be screened for anemia during pregnancy? All pregnant women should be screened for anemia during pregnancy, irrespective of their gestational age at first contact and socioeconomic status. How often they should be screened for anemia? Minimum 4 estimations, 14 to 16 weeks, between 20 to 24 weeks, 26 to 30 weeks, and between 30 to 34 weeks. This is recommended for low risk women. However, if woman has been diagnosed with anemia, she will require estimations more number of times. How to diagnose? We all are very well versed with the history taking, examination, and investigations to diagnose anemia. Remember, gold standard for diagnosis of iron deficiency anemia is absence of stainable iron on bone marrow biopsy, which we routinely don't do. The indications for bone marrow biopsy are failure of our iron therapy when we are suspecting hypoplastic or aplastic anemia, or when we are suspecting Kala Ajar. So I am focusing more on the management. So we have to strike iron when it is hot. It is not only about the iron therapy, but the management of iron deficiency anemia starts from medical nutrition therapy, deworming, oral iron, parenteral iron. Then we have to assess the response, how this woman is responding to all these initiatives, and I will tell you the indications for blood transfusion. So when we are initiating therapy, the aim is to correct iron deficiency, to restore iron reserve, and to correct associated complicating factor. The choice of therapy depends on severity of anemia, duration of pregnancy, and associated complicating factor. So first component of this treatment is medical nutrition therapy. So what is the basic advice which we busy gynecologist can give to this woman? We have to, in brief, tell her about consumption of iron-rich foods, and these are the foods which are rich in iron, that is jaggery, spinach, pulses, eggs, liver, fish, cereals. She has to cook food in iron utensils, adding ascorbic acid, vitamin C compounds in the diet, because that helps for iron absorption from her diet, and also it helps in the absorption of oral iron tablets which we are giving to her. She has to avoid phytates, coffee, tea intake along with the iron supplementation, and intake of iron supplement should be taken in between meals. All healthy facility-based programs where food is being provided are mandated to provide the fortified foods wherever it is available should be preferred. And we do have fortified wheat and rice which are available to us, double fortified salt and oil fortified. It should be preferred by these pregnant women. The second most important component of managing iron deficiency anemia is deworming. Anemia Mukt Bharat 2018 has given some recommendations as far as deworming of these pregnant women are concerned. They have to be given tablet albendazole 400 mg stat to all antenatal patients after first trimester, preferably in second trimester. And WHO 2017 has given us recommendations that where hookworm prevalence is more than 20% or one of the following antithelmatic agents should be given, that is tablet albendazole 400 mg stat or tablet mabendazole 500 mg stat or 100 mg BD for 3 days. If hookworm is highly endemic in that area, that is prevalence is 50% or more, you have to repeat the antithelmatic treatment after 12 weeks of first dose. After this comes the treatment options in the form of iron therapy, oral, parenteral, and if not responding to blood transfusions. So let us see oral iron versus parenteral therapy. We all know oral iron is cheap, easy to administer, and there is no hypersensitivity risk. But the disadvantages are GI intolerance, they are poorly absorbed, variable absorption rates, and it is difficulty in replenishing the iron stores. These are the different types of iron salts which are available with us: inorganic, organic, elemental, and chelated iron. The most commonly used iron supplements are inorganic. Oral iron salts are the mainstay of IDA treatment. It is effective in majority of mild to moderate cases. Common iron salts are ferrous sulfate, ferrous gluconate, and ferrous fumarate. Optimal response to oral iron is generally defined as an hemoglobin increase of 2 gram per dl after 3 weeks of treatment. Whenever you are prescribing oral iron, you have to tell the pregnant woman to take it in between meals, avoid consumption of tea, coffee, milk, or calcium tablet simultaneously with iron tablet. She has to start with the low dose to decrease the side effects, change brand if this particular brand is not tolerated by her, and she can use iron solutions as well. So this is the recommendation by Government of India given in 2018. That is for prophylaxis during pregnancy, you have to give elemental iron 60 milligram daily plus folic acid 500 microgram daily till term, that is minimum 180 days. Treatment during pregnancy, it has been recommended in mild to moderate anemia to give her 2 tablets per day or parenteral iron, and in severe anemia, parenteral iron should be given, very severe anemia, blood transfusion. Postpartum, elemental iron 60 milligram daily plus folic acid 500 microgram daily for 6 months postpartum is recommended. So these are the various common preparations which are available to us for oral iron preparation, but WHO recommends ferrous, which is preferred over ferric because of good bioavailability, acceptable tolerability, and high effectiveness. However, conventional iron preparations, they do have limitations in the form of GI side effects, poor absorption, non-adherence, and there is a slow improvement in the hemoglobin rise. So we also have newer types of iron formulations which are available in the market in the form of micronized, highly bioavailable form of encapsulated iron, which is available in the market. In every webinar, this is the common question asked by our colleagues: can oral iron be given in the first trimester? In our day-to-day practice, we try to avoid it because of severe gastric irritation, but it can be given if it is indicated, and this is endorsed by most of the guidelines. Assessing response, I have already told you that you have to see 1 gram hemoglobin rise in 2 weeks and 2 gram hemoglobin rise in 4 weeks. Now coming to the intravenous iron versus oral iron. We all know intravenous iron has got complete bioavailability, fewer GI side effects, and there is a faster recovery of hemoglobin. But there is an increased risk of oxidant damage, increased cost, and small but definite risk of hypersensitivity reaction. So we have first generation parenteral iron, second generation parenteral iron with us, and the third generation preparations which are also available in the market. But before giving parenteral iron therapy, you have to confirm the diagnosis of iron deficiency anemia. There has to be adequate supervision for management of anaphylactic reaction. You have to stop oral iron 24 hours prior to giving parenteral iron. Sensitivity testing is recommended. However, it is not required for iron sucrose and FCM, and you have to watch for any kind of reaction. This is the formula to calculate the dose for parenteral iron. Now, what about intramuscular iron? The Ministry of Health and Family Welfare recommends use of intramuscular iron after testing as a cost-effective therapy for moderate anemia in pregnancy. However, IM route has essentially been replaced by IV route due to inconvenience of painful injection, dark discoloration of the skin, and risk of myalgias and arthritis. So this is the comparison between iron sucrose and the other forms. When you should assess the response, you have to see the improvement in symptoms, that is improvement in mood irritability in 24 hours, improved appetite should be there. There has to be increase in reticulocyte count after 7 to 10 days, rise in hemoglobin after 2 weeks, and hemoglobin should reach normal levels by 6 to 8 weeks. If no significant improvement is seen in 3 weeks, diagnostic re-evaluation is needed. The indications for blood transfusion in iron deficiency anemia is pregnancy is if she is less than 36 weeks and the hemoglobin is less than 5, or if she is more than 36 weeks and hemoglobin is less than 6. Other indications for blood transfusion in pregnancy are acute hemorrhage with hemoglobin less than 6, anemia not due to hematinic deficiency, and when patient is in labor with severe anemia, that is hemoglobin less than 7. However, you all are aware of the risk of blood transfusion, so take informed written consent and monitor her properly. How you will manage this woman in labor? In the first stage, she has to be given propped up position, adequate cross-matched blood should be ready, adequate analgesia, antibiotic prophylaxis, strict asepsis, monitor for signs of pulmonary edema, and you have to restrict the IV fluids. In second stage of labor, cut short her second stage using instrumentation in cases of severe anemia, and strict aseptic precautions should be followed. Third stage of labor, it has to be active management of third stage, and PPH preparedness is most important. Injection oxytocin 10 IU intramuscular is the drug of choice. Misoprostol and carboplast are also safe. Methyl ergometrin should be avoided. When it comes to postpartum anemia, the cutoff value for anemia 1 week postpartum should be identical to the cutoff value for anemia at delivery, that is 11 gram%, and anemia at 8 weeks postpartum should be defined as by a hemoglobin concentration of 12 gram%. So this is the treatment for postpartum anemia. Mild symptomatic woman, you can give oral iron. Moderate anemia, IV iron. And severe anemia, you have to give transfusion prior to discharge from health facility. So to conclude my talk, friends, apart from all these, some simple measures, they really work wonders. And first and foremost is placental transfusion. Yes, early cord clamping within 1 minute after birth should be avoided. Delayed cord clamping, that is 1 to 3 minutes after the birth or when cord pulsation has ceased. So cord clamping for the prevention of iron deficiency anemia in infants should be practiced and should be hammered to all the practicing OBGYN. And second, very simple tip is iron from the lucky iron fish. This is the iron fish available in the market. It can be dipped when you are cooking vegetables or preparing your food. After your food is cooked, it can be taken out, washed, stored properly, and can be cooked again and again. So these are two simple practical tips apart from the iron therapy and blood transfusions. So friends, take home message from my presentation is preconception counseling and detection is very, very important. screening at first antenatal visit, irrespective of the age of gestation and socioeconomic status, repeat hemoglobin as and when required, deworming has a crucial role to play, medical nutrition therapy, everyone should find out some time, and if you are very busy, should have a nutritionist in your clinic. I have already told you in great detail about the oral iron, parenteral iron, and the blood transfusion. It has to be given in smaller doses every alternate day. Tell her to have adequate intake of protein and vitamin C for better absorption of iron. I have already told you that iron tablet should not be taken with certain foods. You have to test for H. pylori if GI side effects are more. Sometimes liquid preparations are better tolerated. Encourage her to cook in iron vessels or encourage her to have iron fish and do complete hemogram at booking along with serum ferritin. How can I end my talk without talking about prevention? Because prevention is the key. And as I said, our girls, they enter their reproductive career in a iron deficiency state. So awareness in schools and colleges, because we have to catch them young, we have to create community awareness. Premarital counseling should be encouraged, genetic counseling wherever it is indicated, and we have to get prominent people to talk about iron deficiency and iron deficiency anemia in wherever platform they can. So thank you so much for your patient hearing. If there are any questions, I'm here to answer. Thank you. Thank you so much.
Thank you so much, Lakshmi. It was a total, recap of what has been churning in our minds since the last 4 decades. We've talked and talked about it, but somewhere we have failed our girls and women because we knew that this is a big problem. We knew that oral iron is available. We knew deworming we have to give. Everybody knows, but the gap between knowing and doing is somewhere we are stuck. I just want to ask you one question with a new thought. Like the iodine deficiency was overcome by iodized salt, there is a move by the government to double fortify the salt, iodine and iron. That is one methodology where it can reach everybody. Despite the different cuisine in the Indian context, salt is salt. They'll put for everything. So that is, at least you don't have to guide them further. The second is the rice fortification by the iron. So fortified atta, like how we get like that, iron fortified rice. You as a chairman of ICOG, if these 2 things are initiated through the government, what will be the one strong thing that you will do to make this work for us?
See, I mean, Hema, we will not have to do much because salt and wheat and rice is practically used in every household. And if fortified wheat, rice and salt is available, I'm sure with the digital media and all, we can propagate the advantages of having the fortified food, because I already told you in my slide, because that will be really very cost effective, convenient, easily available to one and all. So that will be the best initiative, and we will make it sure that every household, if when it becomes available, should shift to the fortified foods which are available.
Thank you, Lakshmi, because this is becoming a chicken and egg kind of a situation. Because if you in the leadership position campaign that every healthcare provider, every practitioner has to drill it into the girls and women and the families at every touch point, then when they choose their foodstuff, they will look for the label and what is fortified, what is available to them, they will do, so that the volumes will increase and the production will happen. Because now the chicken and egg, why I said, because there are no takers, so the manufacturers are saying it's very cost intensive, and even the transport to the remote areas is going to be like really costly for us. So nobody is taking, so how can we produce? We require tons of it, but only a few kilos are produced, which is no use. So infographics and one strong campaign from your end to just emphasize that in your daily routine, you can make things happen. Your health is in your hands, so go for it. Yeah.
Emma, we can prepare pamphlets, we can distribute to all 40,000 OBGYNs to display in their reception area. Plus, whenever we are taking adolescent health program in schools and colleges, there also we can tell them about the advantages of these fortified foods. And I'm sure we will be able to reach out to each and every household.
Absolutely. Thank you so very much, Lakshmi, for your fantastic presentation. And this is the Shapath. Again, we
Yes,
take
yes.
on this forum
Yes.
that if anything new like this, which is effective and which is user-friendly happens, we will all take a resolve that
Yes, yes.
we will reach it to the last mile. Yeah. Thank
Yes.
you so much.
Thank
Yeah.
you, Emma.
So
Thank you.
now the much awaited panel by Dr. Sadhna Gupta, who has very intently and intensively worked towards making of this panel in a case-based situation with all the galaxy of her panelists. And about Sadhna, I have to say that her work speaks louder than anything else. That is Sadhna for us. And can we have the introduction of Sadhna ji and her panelists, please? Nishad?
Thank you, Dr. Hema and Dr. Lakshmi Shrikande. After that excellent talk on an update on the iron deficiency anemia, we now come to the second session of the day, where we have a case-based panel discussion on coagulopathies in PPH. The panel will be moderated by Dr. Sadhna Gupta, and the esteemed panelists are Dr. Anita Sabarwal, Dr. Asha Niravi, Dr. Devang Patel, Dr. Himali Sinha, Dr. Poonam Goyal, and Professor Saiba Akhtar. Dr. Sadhna Gupta is the Director and Senior Consultant OBGYN at the Jeevan Jyoti Hospital and Medical Research Center, Gorakhpur. She was the chairperson FOXI Safe Motherhood Committee from 2011 to 2014. She was the FOXI representative to SAFOG from 2018 to 2021 and also a member of the ICOG Governing Council. She has several academic honors and many social and organizational awards. She has a number of publications to her merit, including the editor of the Safe Motherhood Initiative, A Silent Revolution, FOXI Focus on Antenatal and Preconception Care, 7 Safe Motherhood Bulletin. Dr. Anita Sabarwal is a FOXI champion. She was chairperson, Public Awareness Committee of ISCCP 2019-21. She is secretary of the Forum of Obstetricians and Gynecologists of South Delhi, past chairperson, Adolescent Health Committee of AOGD. She has organized many updating programs and preventive health camps, also awareness talks, including cervical cancer awareness and prevention. Professor Asha Niravi is the head of department of the OBGYN unit at SDMCH, Dharwad. She is a postgraduate and undergraduate teacher and examiner. Her areas of interest are high-risk obstetrics, diabetes in pregnancy, metabolic syndrome, vaginal surgery, myomas, adolescent PCOS. Dr. Devang M. Patel is a consultant obstetrician and gynecologist at the SIMS Hospital, Ahmedabad. He is the director, Gujarat Fetal Medicine Center and Divine Women's Hospital. As a maternal and fetal medicine specialist, his areas of special interest are hypertensive disorders, multiple fetal gestation, fetal echo, amniocentesis, CVS, fetal reduction, and intrauterine blood transfusion. Dr. Himali Sinha is the professor and head at the Department of Obstetrics and Gynecology, All India Institute of Medical Sciences, Patna. Her professional interests are maternal fetal medicine, social obstetrics, obstetric epidemiology, and preventive oncology. She's a member of the expert group on preparation of guidelines for the Ministry of Health and Family Welfare. She was chairperson, Clinical Research Committee, Patna Obstetrics and Gynecology Society, 2019-20. Dr. Poonam Goyal is a practicing obstetrician and gynecologist for the past 35 years. She has edited and authored several books, has been a faculty at various national and international level conferences, and has received a number of awards, including the APJ Abdul Kalam Azad Excellence Award in 2019. Dr. Saiba Akhtar is professor and CEO of MAMMS Institute of Fistula and Women's Health. She is president, Urogynecology Society of Bangladesh, member of FIGO Fistula Expert Advisory Group, president-elect, International Society of Obstetric Fistula Surgeon, chair of South Asian Group of Fistula and Other Morbidities. She is the innovator of the condom uterine balloon tamponade. She has various awards and publications to her merit.
The floor is yours, Sadhnaji.
So thank you very much for all the kind introduction, and we are fortunate to have such a wonderful panel who have consented to be in this panel, pan-India, across India, and who are academician, head of the departments, and have a national and international presence. So I've been greeting from all the wings of FOXY, whom I have served as ICOG Journal, SAFOG, and welcome all the panelists. And what is Dr. Hema Devakar artist? She is not what we have seen. She is painting the people also. And whatever I am, whatever with all shortcomings or maybe few qualities, it is Dr. Hema Devakar has taken, like she is a part of my personality, and what we have not learned from her, from academics to organization, being tough and soft at the same time. So much to learn from Dr. Hema always. So welcome all my esteemed panelists, and coming to with the basic topic of iron management in routine pregnancies. We are today discussing the hematological emergencies which can be suddenly come out of nowhere. And suddenly the patient is low and we fail to understand that actually what is happening to this woman, this laboring woman, or in the last pregnancy or just postpartum. So there can be sudden, catastrophic and unprecedented. And this is the area that we have some knowledge gap, we have some system gap, and today's with the galaxy of panel, we are going to solve few questions and we are going to give few answers also. So awareness of pathophysiology that these things are there in pregnancy, anticipation of these coagulopathies, and recognize and fast management. That is the goal of today's panel, and we owe our lives to women. And we as a thinker, planner, executor, we have to do much lot. So coming to my first question to Dr. Anita and Dr. Asha, that what we say pregnancy is physiological. Today, certain sections say pregnancy is a total illness. So what is the thin line between physiology and pathology? Because it is physiological and suddenly it becomes pathological. So what is your message that how the pregnancy, what are the physiological change that happens in relation to coagulopathies, and how we should be aware that when it is crossing the physiological line? So Dr. Anita and Dr. Asha.
Thank you, ma'am. Dr. Sadhna, thank you so much. And first of all, before I answer your question, I must say I'm really thankful to you for giving me the opportunity to be part of this great panel, and especially making us the show starters for today's panel. And as you just mentioned, you have galaxy of people but I must appreciate that you have included people like me also, who are working at a very ground level. And we are really very much, connected to the unreached people. So when we are coming here, we will be also part of the learning process also, and we will be able to give your take home messages directly to the people, the community. So thank you so much for giving me the opportunity. So I would like to answer this very, very important question about the physiological changes during pregnancy, because there are significant changes which are happening in the coagulation process during pregnancy. And these changes are adaptive in the process for facing the challenge, that hemostatic challenge of delivery. And since hemostasis is a very, very delicate and dynamic equilibrium or balance between the coagulation process and the fibrinolytic system. So that is why there are a lot of changes in the coagulation process as well as in the fibrinolytic system also. So there has to be a balance maintained. And so that is why there is increase in the coagulation factors. And since as we all know the basics, that we have almost 13 factors, out of which 6 is absent. And so most of the factors, they increase other than few. And especially the fibrinogen, the factor 1, that really increases a lot. And especially it happens during pregnancy, but it is maximum during our delivery time and at the time of placental expulsion. And all these factors, then they come back to their normal state, pre-pregnant state, after 3 to 4 weeks of delivery. And at the same time, the anticoagulants, which are going to balance, like our protein S, they decrease during pregnancy to balance this process. And also the fibrinolytic system, that also decreases. So all these factors, and also we have that platelets, they also decrease during pregnancy, basically due to hemodilution, or maybe we can say due to the destruction process. And also this von Willebrand factor, which is very important, and it happens because it helps in the platelet adhesion, that also increases during pregnancy. So these are the factors.
Thank you, Dr. Anita. You have taken Dr. Asha.
Yeah, madam, just to summarize, ma'am. Thank you,
Yes.
ma'am. Thank you, Sadhana, ma'am, Hema, ma'am. I think we should remember that pregnancy is a hypercoagulable condition, I think, in the nutshell. And for that, we have to pay a price also, because of that condition, the pregnant woman is more prone for pulmonary embolism and thromboembolism. So mainly, to summarize, it is a hypercoagulable condition that we have to remember.
So thank you, Dr. Anita and Dr. Asha, to summarize, because nature is very intelligent and very kind, and the patient doesn't bleed. We have still 10 to 15% of PPH, and rest 75% doesn't have PPH. Despite before the invent of oxytocin, we had, because nature is kind and intelligent, and there is a healing because of prothrombotic procoagulant state. There is a rapid healing, and when the uterus contracts PPH, like it is prevented. So thank you very much, Dr. Anita and Dr. Asha. So after understanding what is normal, because that is the basic of our knowledge, we can have a lot of coagulopathy that can be physiological, what Anita says, Dr. Gestational thrombocytopenia, various sort of thrombocytopenia, which we will discuss, and DIC. Recurrent pregnancy loss is also a part of coagulopathy, and we have coagulopathy as a gift. Patient have APH and PPH, and we get coagulopathy as a gift. We did a lot of blood transfusion to save life, and suddenly we are encountering dilutional coagulopathy. So nature is fine, nature is balanced, and nature wants our intelligence, that how we will understand this thin balance and do best for our woman. So Dr. Himali and Dr. Poonam, with this basic physiological understanding, in routine practice, like we are having so many of obstetrics, 27 million deliveries, 27 million obstetrical patients. How we can anticipate your message to clinical practitioner, that when we should anticipate and take a little time, that yes, this patient can have certain problems. So Dr. Himali and Dr. Poonam, for your message for it.
Yeah, I'd like to start with taking your words that anticipation of coagulopathy in pregnancy is the best start. So when we are seeing the patient for the first time, it's important that we take a good history. Every patient deserves a good history. So we should take history of any bleeding disorder, any family history, as well as any drug that she's taken. Sometimes we keep forgetting to ask her whether she's on any drug, like anticoagulant like warfarin, even aspirin or heparin. Then we should get investigations done. And these include a complete blood count, where we should see not just the hemoglobin, but also the platelets, then a prothrombin time, partial thromboprostatin time if required, and the fibrinogen level. And these could predict a coagulopathy. So history is very important, as well as some of the basic investigations.
So thank you very much. Like we can say if the person is having menorrhagia or she had after dental extraction any bleeding, and a very, very rampant use of anticoagulant, that is aspirin and heparin, for every pregnancy loss the people are prescribing. So this is very important because it changes platelet count also, so many things. Dr. Poonam, your comment on this, that how we can enter. So one message from Dr. Himali, that like with anemia free, with this Shapath, it is not hemoglobin, it is complete blood count, because we want to read possibility of hemoglobinopathy, we want to read the possibility of coagulopathy. Dr. Poonam, your comment for this, any change in clinical practice?
Yes, you have very rightly said, madam, we should not only take hemoglobin, we should take complete blood count, and also take care that what is her platelet count. That is to be watched closely. If it is less than 50,000 or something like that, so in those particular patients, we should be very careful right from the start. And then when we see that there is prolonged prothrombin time, or there is a derangement of APTT in these particular patients, when the prothrombin time is prolonged, then there is a deficiency of factor 7, and there is liver problem in these particular patients, which leads to bleeding in these patients. That is, the extrinsic pathway is mainly defective in these patients. And when APTT is affected, then intrinsic pathway is affected. So in all these patients, we have to be very careful whether prior to our surgery or any surgical procedure, suppose we have a patient of missed abortion or something, we should not straight away go, we HB itna hai and we can go for DNC. We should not do that. We must have our PT, APTT before we do anything. And then whenever both these are deranged, that means the extrinsic as well as the intrinsic pathway, both are compromised, then our patient may lead this may lead to DIC. So we should be very careful in these particular patients. And whenever there is such situation, we should be prepared with blood products before touching the patient to do any procedure.
So thank you. The message is very clear from our both panelists, that first of all, total blood count, keep like we do total blood count, but we have to read it very, very carefully. And in any patient who has the clinical possibility of coagulopathy, then we can go for, we don't do for everybody for the PT and APTT, but when there is a clinical spectrum, then we must have these investigations. So we are ready, and we have to understand that when it is PT, it is a factor 7 deficiency and vitamin K dependent, and when it is APTT, it is the intrinsic pathway. That much knowledge we must have. So coming to with this basic background, that what is physiological and what should be routine for all clinical practices, we are coming to few case situations, and these are all real cases. So she is 32-year-old lady in second pregnancy, first pregnancy vaginal delivery, no issue, no problem. She had a hemoglobin at around 12 weeks, a hemoglobin 10.2 gram. Then she lost to follow-up, which is very common in our setting. And at 34 weeks, she comes into the active labor. Patient, when the admission, at the time of admission, investigation was done, hemoglobin was 11 and 30,000 platelet count. So it will be question to Dr. Devang and Dr. Saiba, but I will like to share what happened to this patient, that she had that count. So patient was given platelet transfusion. So she delivered the baby, and after delivery, she had the intractable severe PPH. So all platelet transfusion, all uterine tympanoid, everything was done, but she had landed up to into hysterectomy, and her platelet count, despite giving quite a good number of platelet and FFP, it remained low. So Dr. Devang and Dr. Saiba, your comment on such situation. And it is so frustrating that we are giving platelet transfusion, but the platelet count is low, and she continued to bleed. So Devang, Dr. Devang and Dr. Saiba.
Thank you, ma'am. Good evening to all. Am I audible, ma'am?
Yes, yes.
So the thing is, when we are giving platelets and the platelet count is not coming up, that means platelet is being consumed somewhere. That is the first thing which should come to our mind. And second thing, we don't have a prior platelet count which is not available in the early antenatal period. So along with the platelet count, we also need to see whether the patient is in DIC by PT, APTT and all the coagulation parameters. Along with this, something which is important to see in investigations, the peripheral smear, wherein you can see lot of different cells like schistocytes, Burr cells, which will give whether, and also the platelets with giant platelets. Also, you need to see the LDH, bilirubin, and the creatinine. So all these things will give us a rough idea which organs are affected, and thereby we can come. And here in what we are saying is that rest of the things are normal and only this thing is affected. So we have to think out of the box, and one of the most common cause herein we need to see is the immune thrombocytopenia purpura. If you do a ultrasonography in such cases, you see a splenomegaly which is increasing in size, and in such cases, adding platelets or giving platelets is like adding fuel to the fire. So it is not recommended to give platelets. Rather, we have to decrease the consumption by giving steroids and IVIG in such cases.
So great, Devang. It is wonderful. First of all, you started, because when the things come up, it is all like hazy picture. So we have to rule out other coagulopathy because she had PPS. So what was the initial? She had dengue or something. So we always remain confused when the patient comes into emergency. So rule out with the quick all tested for like considering HELP, considering DIC, and very, very rightly says, because the patient was being given platelet and she was rapidly, it was consumed, it was rapidly destroyed, and we had no way. So then we have to think the other possibility, and then we come to have this knowledge that this patient can have immunothrombocytopenia, and the treatment line is totally different. Dr. Saiba, your Bangladesh perspective, and how do you find such patient about thrombocytopenia when we are having thrombocytopenia? So please, your country perspective as well as your experience about such situation.
Thank you, Sadhana, for inviting me here, and also thanks to Hema and artist for it. Actually, the perspective, Bangladesh perspective, I think it's not very different from India. It is almost same. Our patients also has irregular antenatal checkup, and we usually, most of the cases, we usually diagnose when the problem arises. But you know, there are some now, as the awareness is raising, especially in the educated group of patients, there may be some that are very few who are on antenatal care, and if we do the blood count during the antenatal care, we can diagnose to them. And you know, this about this thrombocytopenia in pregnancy, we know that if the platelet count is less than 150,000, and it is defined and it is found in 10% of the gravid women, and of these, 75% are gestational thrombocytopenia. Actually, the picture is not very different from Bangladesh, and the point of caution when the platelet count is, if we have if we get the patient during the antenatal period, and at that time, if the count is less than 80,000, we should we should be cautious, we should be very careful about this, and we should evaluate why do women has this problem, and then we have to identify the causes, and then we should treat the patients according to the cause that we identified.
So thank you, Dr. Saiba, very much. So below 1.5, we should be cautious, and at close to term, we get around 75%, frankly, because of the physiological dilution. But if it is around 80,000, we must have the evaluation for all type of thrombocytopenia.
Yes.
And 75% it is physiological, but the other causes, that is preeclampsia, help, coagulopathy, ITP, SLE, infections, dengue is very, like, sometimes we have the epidemic, and fortunately or unfortunately, people in India are very much sensitive to platelet count. They will come to always a platelet count is low and we should eat kiwi and not. So people are now very, very sensitive, at least in Indian clinical practice, about the low platelet count and the hemolytic and the malignancy. So this is very important. And immune, I think Dr. Devang has said, it is steroid and the IV immunoglobulin, and it is the antibody against platelet glycoprotein. And the issue is that we must be ready with the steroid, with the IV immunoglobulin, which is a costly. And Dr. Devang has very rightly said, sometimes we have to do splenectomy. Like we have shared with a few experts that the splenectomy only could save the life. So we that the multidisciplinary involvement is very, very important. So immune thrombocytopenia, a little bit about, for the benefit of audience, that pregnancy does not increase risk of relapse of ITP around 50,000. This is very important, because when the patient is 70,000 and they sometimes force that we should have a platelet transfusion, or ye to nahi ho jayega, what will happen. But our experience have told that if you do prophylactic platelet transfusion, it is not going to help, it is going to worsen the thing. So don't succumb to the pressure. And what he says, steroid and IV immunoglobulin. A little bit, Devang, when we have this sort of thrombocytopenia, do we have the fetal and neonatal consideration also or not? Does it affect, or it doesn't affect on the fetus and neonatal?
Yes. So, ma'am, in few of the cases, it is seen that there is an entity which is called FNAIT, fetal neonatal alloimmune thrombocytopenia, which is common in case of ITPs. And thereby, when we are doing antenatal sonography, we need to see the baby's brain and see for intraventricular hemorrhage also, along when the mother is having such low platelet count. At the time of delivery, if the platelet count is low, that can lead to intracranial hemorrhage in baby also. And even in the neonatal period, it is important to talk to the pediatrician that the mother is having low platelet count. Please see for neonatal platelet count, and if required, that may require transfusion and intense monitoring. Otherwise, it can lead to neonatal complications also.
So thank you, Devang, for very clear message that fetus is also at risk. And sometimes when we are like every newborn and is Indian newborn action plan, we want to reduce the stillbirth rate to the single digit, that it can also be cause of unexplained fetal stillbirth. And it is important that we have to have a check, but the cesarean delivery is also not recommended for the sake of it, that the baby will be like saved of that labor trauma. So it is IV immunoglobulin and splenectomy with the multidisciplinary approach. So we will coming to a little word about inherited thrombocytopenia. That can be a lack of platelet glycoprotein, but the platelet count may be a little like a normal, but they have the severe platelet dysfunction. And these are the two May-Hagelin anomaly, and they can also present as a primary PPH or secondary PPH. So this is the knowledge which we must have. So all golden words from the all the panelists, that CBC is there, have a watch around 1.5 lakh, and when it is 80,000, start full workup, and we have to anticipate the PPH at labor and manage accordingly. So we are coming again to Dr. Anita and Dr. Asha. She is a 4th gravida, 1 suction evacuation, 1 cesarean. She comes with 40-week pregnancy, and ultrasound said it is a 11-week IUFD. she has been, because she had abortion, so she has been prescribed by her gynae ecosprin, folic acid, progesterone. But when it is IOFD, it is 11 week, around 10 to 11 week, and she was advised suction evacuation. And when the suction evacuation was done, suddenly patient started very, very heavy bleeding with the low BP, high pulse, and everything was done, and the blood, there was quite a good amount of bleeding with unstable vital. So Dr. Anita and Dr. Asha, when we do like a simple procedure, it is missed abortion, it is our day in and day out one, and suddenly we encounter that PPS. So what's your what should be the DD in this differential diagnosis in such case, and what the measure should be taken so that the people like attendant are aware of the possibility and we are ready with all the measures. So Dr. Anita and Dr. Asha, your comment.
Yes, ma'am. I think it is a case of miscarriage. So I think when it is a miscarriage, I think we are all taught in the undergraduate that there can be a dead retained products of conception. They are more prone for DIC. So usually we'll be counseling them, patient and patient party about it. And now there are other differential diagnoses also, because in the era of nowadays we are seeing more cesarean scar pregnancy. So that is also very important, that if suddenly she starts bleeding means we should think about cesarean scar pregnancy. And definitely if it is a case of mid-trimester abortion or molar pregnancy, these are the other things we should keep it in mind as a differential diagnosis. And other thing is help is not so common in such early this one. But suppose she's on heparin or low molecular weight heparin and all, then we may expect such a bleeding, madam. Mostly miscarriage, we are always little on the guard that we will get their coagulation profile done. First platelets, and if we find they are abnormal, immediately we ask for this one, coagulation profile. And usually in advance, sometimes we take a consent also for blood transfusion and keep, because yeah, this is my
thank
Anita
you very
madam
much. You are very clear. Anita, Dr. Anita, you want to add something?
Yes, yes. Even sepsis, which is,
sepsis,
along with, especially with Staph aureus or Streptococcus pyogenes. So even that can lead to coagulopathy. And also, like, then we must do the ultrasound also, focusing on the scar, so that that could also help. And also we must do LFT and KFT also before that, so that helps in
So one message that even in the late first trimester or early second trimester, the simple suction evacuation can be very, very hazardous, and we should not take. First of all, the attendants also take it. We will go in 1 hour, and suddenly you are saying that blood is needed, and suddenly, because our system gets like all uncoordinated, so sepsis is there. DIC because of the thromboplastin activation, because it is a missed abortion, and it is not that less. It is the recent paper that it is around 1.6% incidence of coagulopathy in the missed abortion. And what Dr. Asha says, that the molar pregnancy is another thing. Always scar pregnancy and be scar pregnancy minded in cesarean section, because many times it will say it is it is a missed abortion, and you suddenly know, because and every ultrasound you must be scar pregnancy minded. So this is all that this simple case can turn up into the disaster if we don't anticipate, we don't recognize, and we don't treat it well. Coming to third case situation, this primary gravida regular ANC. At 32 weeks, she had recording 140/90 blood pressure, edema on leg. She was prescribed lobetalol. After 10 days, she complains with the mild tenseness and the reduced fetal movement. Blood pressure 150/100. Fetal growth 7 days retarded, and this is the finding: HB 10.2, platelet count 1.2, bilirubin 1.2, SGOT, GPT mildly raised. She was given Udiliv, nifadipine was added to lobetalol, and to monitor blood pressure at home. So after 1 day, patient come with the more 160/100 millimeter mercury's blood pressure, no fetal heart sound. So it was a abruptio, like what is 32-week IUFD. Because of everything was normal, coagulation profile, LFT, KFT, HB 9 gram, she was advised oxytocin induction. And she had a good progress, delivered after 4 hours and placenta delivered, and after 30 minutes of placenta and the baby delivery, she started having heavy bleeding with unstable vital. So Dr. Devang and Himali, what I think we will not go what went wrong. That obstetrician was alert, but IUFD, so normal delivery, vaginal delivery, and what happened wrong, and what went wrong, what was wrong, and what was right, and what is your differential diagnosis? You have been called for managing this case. Devang and Dr. Himali. Yes.
Yeah. So, ma'am, if I can see, if we take a proper history, then the patient is clearly said that there is decreased fetal movement, and at that point, the lab parameters were deranged. So, if we see that, then that patient is going into health syndrome, and that is the point wherein we should act rather than waiting and sending the patient off. Whenever we are not clear, it is better to admit the patient and see within 12 hours how the labs are behaving, and then take a call on it.
So thank you very much, Devang. I will really emphasize this issue, this point. Then whenever there is a pre-eclampsia suggestive of, admit the patient for 12 to 24 hours. Don't send her home, and see what is happening in her body. So this is the golden words from you. Don't send them home. Patient, keep and watch on this sort of picture. So Devang, please go on.
Yes. And when we see that after the delivery, there were retroplacental clots, so that clearly suggests that there is abruptio placenta. So the two possibilities could be HELLP syndrome, and there could be a patient going into DIC with abruptio placenta and IUFD. When there is IUFD and abruptio, we know that this is a significant abruption, and abruptio placenta is the most common cause of severe postpartum hemorrhage. That is the most important high risk factor. So when there is APH, yes, there are two things. One is mechanical, and another thing is that there is a consumption coagulopathy. All the coagulation factors are used up. And so we anticipate it's a kind of mixed variety of PPH, wherein there could be atonic as well as coagulopathy. So the next step would be resuscitation, wherein you need to first see the circulatory system resuscitate and evacuate the uterus. And third thing is replacement of the coagulation factors with the various blood and blood products.
So Devang, we will come to that point. We will like a very, very valid point and very, very important point. Dr. Himali, just at this moment, we will just have a check. Dr. Devang said we can have atonic PPH, we can have DIC, we can have HELP also, because patient was already in pre-eclampsia. So your Himali, your quick take away what you teach to your resident, that how we can have a quick differentiating from the HELP from the DIC and HELP from the thrombocytopenia. So Dr. Himali, your tips.
Sometimes HELP and DIC, they can overlap, but we need to differentiate the two. So the history will help. Here again, we are seeing the background that the blood pressure was raised in this case, and the liver enzymes were also deranged. Of course, the platelet count was low. But if we have done some more investigations like the coagulation profile, we would have found that in case of HELP, the fibrin degradation products and these are not raised, whereas and fibrinogen is normal. The fibrinogen level. Whereas in cases of DIC, it's a consumptive coagulopathy. So these levels are quite, the FPP is quite raised, and fibrinogen level is quite low in these cases. So this will give some idea that it could be two different, and the management, of course, will depend on the background condition.
So very, very important, Himali, you have said first thing, both can overlap, both can come together, because pre-eclampsia, everything is hand in hand. And what is the differentiating feature? That platelet count may be low in both the situation, but the coagulation profile is not deranged in HELP. It is the hemolysis, evidence of hemolysis, elevated liver enzyme, and the low platelet count. Just for all the audience, we want to say one thing, that you have to be very careful in listening to these patients with the what we say mild preeclampsia, because there is a question, and now the ISHP actually says that don't say it is mild or severe. It is always preeclampsia, because we never know. Today it is mild and tomorrow it is severe. So all practical purpose, but listen to these patients. There are only mild symptoms like viral flu, upper quadrant pain, a little malaise, a little headache, a little blood vision. So listen to your patient, and this patient can have a full-fledged help. And these are all coagulopathy which can be mistaken and which can overlap, and it is the evidence of hemolysis, it is platelet count, and we can have the overlapping picture. What Dr. Devang and Dr. Himali said, that we can differentiate with two things, that is coagulation profile and the platelet count and the plasma fibrinogen level. So these are very, very important message. At this point, we will like to have opinion of Dr. Saiba, that how like the coagulation profile is so practically done in your country, and what is the situation in Bangladesh about it?
Actually, the situation it's different in private sector and in government hospitals. In government hospital, usually our patients are usually, comes in a very emergency situation, usually from poor group of poor patients, and they are diagnosed during the emergency. And in that situation, we don't have much facility for investigations. Very simple, or sometimes people call obsolete, but we still use blood clot observation test and also bedside test. Then we send the blood, but the problem is getting the report of these investigations. It takes long time. By this time, at that time we have to proceed with our treatment based on the patient's clinical situations. There are many the maternal complications in HELLP syndrome, like where you already told, in case of abruptio, in eclampsia, there is a HELLP syndrome, and HELLP syndrome and DHC, it overlaps with each other, and there are different situations. So, and patients, we need to observe the patients, or clinically examine the patients, and when the facility comes, we do the liver function test, we do the kidney function test, and we know the renal failure is very common in DIC and also in HELLP syndrome, and maternal mortality is also high. So there are different life-threatening complications can be developed. In that situation, actually, we do the management according to the based, mainly start with the based on the clinical observations and our findings, and then when we get the report back, usually it takes time. But when we are doing the private sectors, we can get the reports earlier. Then based on the reports, we can proceed in the management.
Thank you, Dr. Saiba, which is a situation, actually what you have highlighted one very, very important point, that we will just discuss the bedside test, because in such situation, we want minute-to-minute change. And with the bedside test, we can have an eye. It may not be that accurate, but it gives you insight. And so many times in many of the settings, we get 2 to 3 hours minimum or 1 hour to minimum, and the patient is bleeding and having unstable vital. So nothing is obsolete in this world, actually. Everything has got its place, but we should be ready and we should learn everything with respect. So this is very important. And what we say, we can have all the complications like subcapsular hematoma sometimes, which is life-threatening, and ARDS and DIC. And again, the HELLP also had got the same thing. It can have the perinatal complication, and that's why we have full-fledged HELLP. We don't want to continue delivery. It is a contraindication of the expectant treatment. We must terminate the delivery after steroid priming. So it is again a cause of sudden IUG or sudden asphyxia, sudden stillbirth. So that if it is no IUFD, we might not land up into all the DIC and something. Management HELLP is to be taken as a severe preeclampsia. This is one important message we want to give. So Maxelf is there for seizure prophylaxis, antihypertensive in full way, and platelet transfusion again around 40 to 50,000. So it is a form of severe preeclampsia. We are discussing coagulopathy, but it is a form of severe preeclampsia. So Maxelf steroid is like a question mark, but it improves platelet count, not the course of disease. This I want to say, that it does not affect the prognosis, but it improves platelet count. And what we will just discuss the blood component, and we will come. This is important slide. Again, I say that ISSH, which is a very people-friendly recommendation, it does not recommend health management as a separate entity. It present that it should be managed as a severe preeclampsia and taken as seriously. So it is a revisit. It is, we have to, we can revisit, we can plan, act in our own setting. So
And I just want to add,
yes,
and
Dr.
for this,
Saiba,
what you told, revisit is very important. And we do the PPH drilling in our hospital, we take an initiative for eclampsia and PPH. So we also do these sorts of, case management or PPH drilling, a sort of scenario-based practice, even when the patient is not there. So simulation practices and hanging the management on the labor ward and other important places where these patients come. That helps us in recapitulating and revisiting the important issues, important points in management.
So thank you
I'm
very
sorry
much.
to interrupt.
Yes, Devan, yes.
Ma'am, I just want to know, are we going to discuss thrombotic microangiopathies and differentiating with health later, or shall I?
No, you please do it, because we have, I think,
Yes.
15 minutes, 10,
Yes.
12 to 15 minutes we will wind up.
So ma'am,
Please, Devan.
there is one spectrum which we are going of microangiopathy, right from severe preeclampsia, HELP, acute fatty liver of pregnancy to all the thrombotic microangiopathies like HUS and TTP. Now it is very important to differentiate, because there is the difference is the minutes to hours in delivery, and second is to deliver or not to deliver, or is delivery going to help us or not. When we are talking about thrombotic microangiopathies, delivery is not going to improve the situation, and therein platelet transfusion is not important, rather management in the form of steroids is important in HUS and TTP. Now, differentiating HELP we have already discussed. Second is acute fatty liver of pregnancy, wherein there are overlapping features, but key important thing is severe hypoglycemia. And second is early derangement of PT-INR and renal involvement. If renal involvement is disproportionate to the clinical picture, then you should think in terms of acute fatty liver of pregnancy, wherein you require very urgent delivery, and the risk is even more than HELP syndrome, and which may later require hemodialysis also. When we are talking of thrombotic microangiopathies like TTP and HUS, there is one mnemonic which we call as FRANT. If the patient is having F for fever in the past 2-3 days, R is renal involvement, A is anemia, that is the hemolytic anemia, N is the neurological signs or symptoms which is seen more in TTP, and T is thrombocytopenia. So FRANT, if you see this, then this could be thrombotic microangiopathies, and which require some different management, and it is more severe and requires more intense management. So this differentiating.
Devang, thank you very much for it. Actually, you have summarized my last slide, that is what an obstetrician must know about coagulopathy. So very, very nicely summarized, and we should be aware of that, what works in that, and how we can say acute fatty liver, hemolytic uremic syndrome. It may be uncommon, but it comes into the all dicey picture. They come as a disguise, and we have to have in our mind that what is the minimum basic knowledge as obstetrician must know about the coagulopathy. So I think Dr. Saiba has already taken it a little bit. Poonam, Dr. Poonam, DIC a little bit, I will say HELP DIC, what is the clinical situation? I think we will wind up in 12 to 15 minutes. What is the situation like? It is what we say, na, so many coagulopathy. Sometimes it is overlapping, it is coming. So what should be
So
the
there is
diagnostic point for the DIC? Yes, Poonam, Dr. Poonam.
There is lot of overlapping, as you just said. There is lot of overlapping. Sometimes it becomes difficult for us to make a diagnosis. And whenever there is PPH and preceding to PPH, if there is DIC, then the situation becomes very dreaded, because when there is consumptive this coagulopathy, then there will be deficiency of our blood, coagulation factors, which will further lead to bleeding and finally to thrombosis and finally multi-organ failure. So our main aim is to diagnose what is the cause of PPH first. That also is to be taken care of with the management of DIC.
So one thing very important, that every point of DIC diagnosis start from the inciting event. Every professional body and every says, if you don't have the inciting event like preeclampsia, like abruptio, like a PPH, like history of, then we will start thinking of DIC. So this is very important, that what activates the coagulation cascade, it is the obstetrical inciting event. And what is it? Abruptio, embolism, IUFD, sepsis. Sepsis, we are like not discussing, but it is one of the very, very important issue in obstetrics. It is a silent killer, and the DIC comes the evident killer. APH, PPH, all abortion, what we have discussed, and molar and the HELP syndrome. So the inciting event is very, very important. And again, I will say, Dr. Anita and Dr. Asha, we will say Dr. Saiba told about bedside test.
Yes,
your experience are little stick to our younger generation, that how we do this simple bedside test and how it helped. Dr. Asha and Dr. Anita.
Yes, ma'am. Yeah, the bedside, it is called as a Wiener's test, where we draw the blood and around 10 to 15 ml, put it in the 5 ml and put it in the test tube and leave the test tube for half an hour. And if the clot is very strong and nice, means we know that there is no DIC, means the serum fibrinogen is almost around more than 300 to 400. When the clot is not very stable and very friable, means we know that there is a hypofibrinogenemia. But this we are not actually very good test, but we are not doing it. And most of the time we rely on this coagulation profile, and we also have a facility to get our D-dimer test done. So they are slightly increased. So we make a diagnosis of DIC depending upon that, and definitely the risk factors we look for. So we become DIC minded when there are risk factors. And Anita madam can add something. This is Anita, what we do is.
Yeah, actually, ultimately, it's the fibrinogen, low level of fibrinogen. That is the hallmark to diagnose DIC. But nowadays, see, even in COVID, we are talking of D-dimer, D-dimer. I'm really very curious to know everything about D-dimer. So again, this is, that fibrin degradation product. So they are talking about this. So whenever there is degradation, so ultimately, these things they rise.
So thank you very much, because yes,
ma'am, I want to say something. When we were in earlier days, when we were not having these coagulation tests, I remember in our college and PG days, in all missed abortion patients, we used to do this clot retraction test.
Yeah, clot retraction.
The patient to the OT and then show it to madam that see.
Yes.
No, I have been doing in my clinic, because see, mine is a very primary level clinic, which I started in '84. So I have been doing, though I had the lab also later on, the pathologist used to come, but I myself used to do breathing time, clotting time, and this whole clot retraction. So
because actually it is just in front of you. You are seeing it.
You can do it yourself.
It is just in front of your eyes.
Yes.
So I am also for it, that if nothing, it is very important, because again, it is a point of care test. Thrombocytopenia is not specific to DIC. This is one important thing. And what we have, the global coagulation panel, it is all prothrombin type. It is normal values 10 to 13 seconds, and PTT we have done. It is fibrinogen level, it is very important, which again we say it is, if the clot is like having in a reduced, it is soft, not reduced in volume, and over next 30 minutes, it becomes quite small. It is almost correlate to the fibrogen level 50 milligrams. So this is very important. And one of the very, very important marker, the patient who will have PPH, then if the fibrinogen level in antenatal period is less than 200 milligram deciliter, it is a almost 100% prediction of PPH. So it is one thing, again, in high risk population, we can consider it. And D-dimer, you have said that it is not present in body as usual. So if we have D-dimer, it is very, very strongly indicative of DIC. And PPH and DIC, what I'm saying that how we can predict PPH, it is unpredictable what we teach, but the fibrinogen level, if it is less than 2 gram per liter, it is a 100% correlation for a severe PPH. So this is one important thought process which we want to give to the patient. We can send the patient to the higher tertiary care or where all facility of blood component is available, because it is planning. Today medicine is always is a planning and prevent the complication. We don't want to be very we had a very daring obstetrician, but now we don't have that there. We want to plan. Yes. Dr. Devang, you are in the corporate setup. Have you used thromboelastography? One is the bedside. It is one spectrum coagulation profile always. Are you have any experience for thermoelastography as a point of care test? And you see any future for in obstetrical care or obstetrical HDU system?
Ma'am, we have in our corporate hospital, because there is a cardiology, cardiothoracic surgeons, and they use it. But we have not used it at all, because its implication is very limited. But yes. Its importance as 3 days back, we had a patient who, after second trimester miscarriage, has severe bleeding, came to our hospital with uterine pack, and there was severe bleeding. At that point, after obstetric hysterectomy, even there was oozing bleeding from it. So now I don't know whether it is due to DIC or some surgical site blood loss. So in that way, while we are waiting for some lab parameters, if we have something like TEG, then that will quickly guide whether this is due to some surgical cause or DIC related. So its implication in such limited cases there, and it's important. But as of now, we are using other lab parameters for blood and blood products.
So it has been propagated quite a lot that it can be a good point of care for diagnosis, what you say, surgical site bleeding or a coagulopathy, and secondly, what component to be given for this. But what I have gone through, that the graphs and this thing are still complicated, and it is interpretation of those graphs is also a thing to learn for all of us. And there is always emergency bedside ultrasound, very important, because we know that it is hematoma, something fluid, it is sepsis or what it is. So thank you very much for this sharing about thromboelastography. Anyone take about the scoring system for pregnant and non-pregnant? Any issue that it is useful or not? Dr. Himali, your comment for this about the scoring system in DIC. Does it help or it is okay?
Scoring system in pregnancy actually is this is not much useful, because it doesn't take into account the physiology of pregnancy, this scoring system. So out of pregnancy, it is good, but I think during pregnancy, we are not using it. During pregnancy, it is not of much help.
So thank you very much for it. Again, I say, if there is no insightic event, do not use this logarithm. And what very rightly said, many professional bodies are objecting on it because it doesn't take the physiological procoagulant status, what we have discussed in the beginning. So there are few society who have said it is a obstetrical specific DIC severity, and hope in your teaching institution like AIMS and in corporate even we can use this DIC severity status which consider the obstetrical physiological. So this is very important thing, and we can do a lot with our own practice. So it is a final diagnosis. It is, I think we have covered, and prioritize management. I will say quick before we take the last case that urgent priorities treat the cause, like evacuation of uterus, termination of delivery. It is all supportive therapy. So we will come to like I think Dr. Saiba, what is the issue like component therapy? How much it is available in your country? And any expert will say that in DIC, how do you like plan? You do FFP for plasma expansion, for maintaining circulation, or only for the coagulation profile? A little comment about the blood component therapy. And Saiba, your country perspective about availability of blood component.
In our country perspective now, the facility is getting increased, especially it has increased after this COVID situation. There are importance, and we have dengue also. So, women's health is not that important. When the situation affects all the population, when the man involved, it gets priority. So based on that, for the management of dengue and corona, so for the management of the corona patients now, the availability of the blood and blood products, it is more available. But I must say it's not really easily available. Sometimes it takes time. When this DIC happens, what happens? That there is some basic causes. So when we come through these patients, first we have to in DIC situation we have to hold the progress of the coagulation problems. We have to maintain the coagulation problems, and another important thing is we have to deal with the underlying cause, like as already has been discussed, if it is a preeclampsia, if it is an IOFG, IUFD, if it is an abortion case, we have to do this clinical management, but simultaneously we have to manage we have to do the management of the patient, like maintenance of the fluid balance and giving the blood product. And these patients sometimes come in shock and also in very serious conditions. So whatever problem they have, if they have respiratory problems, we have to address that also. If the patient have and maintaining the fluid balance is also important. And in that case, we must be very careful, because if we cannot restore the adequate tissue perfusion, in that case there may be there may be problem in the restoration of the procoagulant synthesis, and the patient may deteriorate. So these are the important issues which we should be careful and we should be addressed.
Thank you, Dr. Saiba. You have taken a very, very important point, that if we maintain perfusion, organ perfusion, then there is a synthesis of procoagulant and there is a elimination of the all fiber D dimers. So the maintenance of circulation is the crucial, with very, very hard effort of all FOXY leadership like Dr. Hema, and like we are fortunate that we are having good component therapy, I think all over country, but still like in Northeast, when we do this thing, still there is a issue of availability of blood component. So Dr. Hemali, you are in AIMS Patna, and Dr. Devang, you are in corporate sector. We want a quick comment that how we should choose the blood component, because it is Hamisha, always obstetricians are blamed that unnecessary, they like not order so many blood and sometimes so many issues. So Dr. Himali and Dr. Devang, your comment about judicious use of blood component in DIC.
In DIC, we require component therapy. We, along with, because the patient is bleeding also, we require to give a PRBC. Along with that, we require to give our FFP for the coagulation factors. And because platelets are low, even that we require to replenish the platelets as well. So we need to give all the three components. And now, as of now, we are saying that this should be in the proportion 1:1:1.
Devang, this is Dr. Himalias, and this is my question, 1:1, because we talk so much about massive transfusion protocol that at many times what I understand from doing all educational program, that from the very beginning people start 1:1:1. So Devang, when this 1:1:1 or 1:2:1 protocol start, it is from the first PRBC or it is after 4 or 5 PRBC? So
It is-
where this protocol starts?
After 4,
It is after 4 to 5 PRBC, and that too in a very short span of time, wherein in 3 hours or 4 hours we are giving this many blood and active bleeding is there, wherein there is consumption of coagulation factors. And ma'am, one point I would like to add that once we have given given the correction factors, and then it may repeat the lab parameters. And when we repeat the lab parameters, we don't have to treat the lab parameters, we have to treat the patient. We have to see the clinical condition. If there is no active bleeding at that point and that range is coming towards normal, we don't have to like correct the factors right within 12 hours. That let the body take its time and correct it by itself rather than giving the products, because this products giving it is like a double-edged sword. Like it has its own complications also. So after initial products, if there is no active bleeding, better to wait and watch and monitor.
Thank you, Devang. It was wonderful that you treat the patient, not the lab value. So no knee-jerk reaction, because actually with the so much of, intensivist are all the help of affair in all the webinar and the conference, and suddenly people have a overreaction, and every like platelet transfusion has its own issue. It is sepsis, it is autoantibodies. So the first of all massive transfusion protocol start after 4 or 5 PRBC. We have to take the clinical picture. If the patient is fine, you have corrected the etiology, she is bleeding, she is not bleeding, and she is stable, then we should stop. Very, very important. And FFP is not a plasma expander. It is a correction of coagulation factor, and cryoprecipitate, especially when we have a low fibrinogen level and the patient does not also tolerate the high amount, like in severe anemia or in the like a pre-eclampsia when we don't want to overload. So platelet has its own, again 40-50,000, and I think Dr. Devang and Dr. Himali has taken about it. Any experience about the new, like a costly thing that is a recombinant factor 7 in DIC and the pelvic arterial embolization? Any experience? I think Himali and Devang and
Yes,
who are in the institution,
yes,
actually.
Yes.
And Dr. Asha, your comment, if you have any experience about it. Yes.
Yeah, ma'am, I know we don't have a experience of doing a pelvic, what you said, that
arterial embolization.
Embolization. And also one more thing, that was what you said, ma'am.
Recombinant factor 7.
Yeah, that also we don't have. We are not
any
having
experience.
that.
Any experience?
No,
I think Devang, you have.
Yes.
Devang and him, ma'am.
Yeah. Ma'am, one patient we have used recombinant factor 7, that too with the recommendation of the intensivist. That was a dengue patient who had 20,000 platelet count. After the delivery, she had a lot of PPH. After correction of the factors, still there was bleeding, oozing after uterine tamponade. So that was given. It cost 70-80,000. We don't know how much it helped, but the patient came out. That is one thing. Costly risk is thrombosis. About the pelvic arterial embolization, I think it is very useful where available, but we need to know the indications. Its indications is not in when you have done laparotomy, but if you have a vaginal delivery, you do a ribbon gauze packing or Bakri balloon tamponade. And even after that, if you feel there is oozing, suppose if you are doing ribbon gauze packing and that 10 or 11 packs you have put, and still you see at the end of the tail has become soaked or there is oozing, in that case, of course, there is derangement of the coagulation factors. And if you have immediate pelvic artery embolization intervention radiologist available, if you do that, you are decreasing the pulse pressure and thereby preventing a laparotomy, because laparotomy in DIC has its own complications. And of course, if you do not have pelvic artery embolization facility, then laparotomy and obstetric hysterectomy or internal artery ligation is the answer. But yes, say in cases of jaundice, wherein there is derangement of PTINR is deranged, in cases of a very low platelet count, these things really help. Because in pelvic arterial embolization, the intervention radiologists just require a platelet count of 50,000. If INR is deranged, they are happy because they have to just put one needle. That's it.
So thank you, Dev. And Dr. Himali, your experience with recombinant factor or interventional radiology, because Dr. Asha is in the medical college head and it is availability issue is there. Expertise issue is also there because it is not like everyone one should be expert. So Dr. Himali, your comment on this high tech.
I don't have any experience with recombinant factor 7, but yes, we have used intervention radiology once in our setup and it did help.
So thank you very
Ma'am,
much.
in my center also, we had used this arterial embolization. That patient was of cesarean scar pregnancy. Sac was almost about to bulge in bladder. So in that patient, we did first embolization and then did DNC and then stitched the scar and patient came out well.
Thank you,
She
Dr.
had one
Poonam.
IUD first, that was because of gestational diabetes, which was not diagnosed. So she didn't have any baby. So we tried to conserve the uterus in that particular patient.
So factor 7 has got its own issue, but two things which I want to communicate, that if it is to be used, then it should be used earlier in the logarithm, because in the very low plasma fibrinogen level and in very severe coagulopathy, it is not going to help. So if you have and the patient can afford and you would think that it can help, then use it early, and it is a costly. And one concern about it, that around it is 1 out of 46 the patient can have a thromboembolic phenomena also. So be careful for its use, but it is a thing which sometimes works, what Dr. Devan says, and the pelvic arterial embolization, like we have certain very, very positive remark that in morbid adherent placenta, if they are expert, they are like having embolizing even small vessels, but that expertise availability is still an issue. But what the today's research says, that if the DIC score is very high, then it is not that much of effective.
That useful.
So we will leaving tranexamic acid and heparin. Any comment, Dr. Poonam, you take that you use any role of tranexamic acid and heparin, because PPH we want to give, and
ma'am, we are using this, and this is definitely helpful. We use 1
helpful.
gram. It's definitely helpful.
Not in PPH, it is coagulopathy actually. In the DIC,
no, not in that.
Not
in simple
in
PPH, whenever we suspect that patient may bleed, we give prior to.
So prior, that is preventive, but in a frank coagulopathy, actually these drugs are not to be given in frank coagulopathy. So no confusion about it. Once upon a time, we used to say how heparin can help. Only in very, very rare cases when there is a like a issue of the very, very rapid thrombosis, very, very microvascular thrombosis. So it is the Dr. Devan, it is the slide what you summarize what an obstetrician should know. Rising creatinine, low platelet count, neurological feature and cystosis, it is TTP. I think you agree with it. Similar feature without a neurological involvement, but with rising creatinine, HUS, and if there is a sign of hemolysis and liver enzyme, this is help, and again the preeclampsia. We need obstetrician as a lead and a team of dedicated colleagues like hematologists, intensivists, and this is the last. We will take 2 or 3 minutes with the permission from Dr. Sheetal, Purva, and Dr. Hema. Patient, she had a delivery fine 15 days ago. She was on the episiotomy. She was given ibuprofen, paracetamol, and she come on 10th day with the quite a good moderate amount of average with the hemoglobin 5.1, and this is the finding. So Dr. Anita and Dr. Asha, when the patient come with the 10th day with the PPH, with that low hemoglobin level, platelet count is okay, prothrombin time is also a little okay, and fibrinogen is also around the lower limit of normal. So what you consider as a like a differential diagnosis, and do you consider any sort of coagulopathy with drug induced or something? Dr. Anita and Dr. Asha. Dr. Anita, yes.
Yes, ma'am.
Yeah, Dr. Asha.
Yes, yeah, because she's taking a lot of NSAIDs, then I think they can cause some platelet dysfunction, ma'am, and it can cause secondary PPH. And again, there is something called as Van Willebrand disease, which may manifest in the postpartum period, because usually Van Willebrand factors start increasing and it is maximum at 32-34 weeks, and after postpartum it start decreasing. So it may manifest in the postpartum period. That is one, this one. Or also I can think of sepsis induced DIC, or it can be a case of TTP also, madam. So these are the various
So
my
these are the
differential.
diagnoses. Dr. Anita, one question that why she had this thing and why she didn't have the PPH as a primary postpartum hemorrhage. So she was diagnosed as a von Willebrand disease, and why the patient does not have the PPH primary, or she could have or she could not have. Dr. Anita, your comment about it.
Yeah, because actually there's a history of menorrhagia also. Already she's giving history of menorrhagia and she had anemia. So we are thinking maybe she had that time only this von Willebrand disease. So that is why this is what I feel.
So I think we have come at the beginning now. What you have said, you have started this panel discussion that the procoagulant factors are more in the in the pregnancy, and when even the patient has some inherent coagulation disorder, nature is that kind because nature wants every woman to reproduce safely.
Right.
So they have the higher concentration of VWD factor, and when the patient delivers after 10 to 15 days, she comes to the back to normal, and she can come as a coagulopathy, and she need a different mode of treatment again with consultation with transfusion medicine and hematologist. So it is drug, it is sepsis, it is a coming back of coagulopathy, and this is we should consider it because ultrasound is normal. Everything is normal in secondary PPH, but that is 5 gram hemoglobin. So patient need diagnosis, patient need management, and this can be the opportunity for future her lifespan. Because with pregnancy, it is not a problem, it is actually opportunity to solve the thing because she has been diagnosed and she will be treated accordingly. So back to again, that hematological emergencies can come suddenly, catastrophic, unprecedented, and we need a lot of things. So one line message from all learned analysts that what we should do to every care setting, to all obstetrician, what we should do to anticipate and to diagnose and manage. In the public, in the whole system, not only in the clinical, but in the whole system. So Anita, Asha, we will go in the way. Yes.
So I'll start with the primary level because at the primary level only we can do lots. Because if we take a proper history and we take, the basic investigations, and if we just concentrate on them, we can really take out so many things. And we know that these things can do harm in future. So we can take care at that time only.
Dr. Asha?
Yes, ma'am. I'll always sensitize everyone that pre-eclampsia, think help, ma'am. This is my important line. Pre-eclampsia, always think of help and rule out it.
Yes. So it is a form of severe pre-eclampsia. Devang, Dr. Devang, your message?
Cross-match for all patients for delivery.
Great. Dr. Hemant, cross-match, Devang, just we are running over time, but if we do cross-match, do they use that blood or it is wasted or what happens? Because in our setup, they say,
Ma'am, it costs 500 rupees for a person coming to our hospital, taking the sample and keeping one blood ready, if in the blood bank. So if it is not used, it is used for some other patient.
At least we will say low to moderate risk, if not at all, if not all. Dr. Hemaldi, your comment? Dr. Hemaldi.
That's what I said right in the beginning. When you look at the CBC report, go beyond the hemoglobin.
Yes. So we become a lover of CBC actually. It is a platelet, it is hemoglobinopathy. I am a strong proponent. We can diagnose, anticipate hemoglobinopathy also with the good CBC. Dr. Poonam, your message?
My message is that every obstetrician should be aware of how to give blood products and when to give what blood product. They should be aware of that.
Great. Yes. So we need to know that thing, what I say now, because people are so 1:1:1 that I am really worried that from first transfusion they are doing 1:1, and that is really like we can say wastage of a very, very valuable human resource. Thank you, Dr. Poonam. This is very important gap. And Dr. Saiba, your last message as a
most of the medical points has been already told. My point is we are clinician, but we also has a responsibility public. So raising public awareness about these problems is also important, especially when there is some problems and patient is anemic, the problem becomes more. So prevention of anemia, we need to raise the awareness among the public and also among our professional groups about the possibility of these problems. Just remind them time to time so that.
Thank you, Dr. Saiba, because in India, what
Very
is
good
my
point.
experience is that few people who are having lowest risk are having maximum investigation, and people who are really needed, they are not getting the privilege of even the basic investigation. So it is all about disparity in human life. It is a disparity. It is not our knowledge, because every people you say 12 gram hemoglobin and she will come with all iron binding capacity, transferrin receptor, and it is really aching. Dr. Saiba, thank you very much. And with this, I seek my earnest support for my presidential candidature. Thank you very much for wonderful panel and wonderful input.
Thank you,
It was
ma'am.
really
Thank you, ma'am.
Thank
Thank
you.
you, Hema ma'am, and thank you, Sadhana Gupta ma'am.
Yeah, thank you, and
I
very
really
good
can't
wishes
thank you ever so
for your
much.
election.
Very, very interesting panel and very, very important points driven home. Heartiest congratulations to the whole set of people, including Saiba, who has joined us from Bangladesh, Devang, Anita, who presented two grossly different perspectives of corporate to the grassroots. You know, that was such a contrast, and it was so beautiful. And the institutional, Himali and Asha, coming up with their own points, and of course Poonam giving her insight. Sadhana, you've all the time been asking the questions. I want to ask you one thing. Now you are going to be leading a big organization, hopefully in the near future, and many people now know you. So, and in and around there are so many small towns and places near Gorakhpur. Have you oftentimes thought, yours is a rather big setup, so yes, even knowing you, knowing the quality of your work, knowing the name, having the connect, having a rapport, they will from smaller places send the patients to you, okay, with the complete trust that ye to kuch to bhi karegi, okay. Half the time or more than that, have you ever felt they should have sent this patient before, they should not have missed this, they could have done this, that and the other? Can you tell us one such story where you thought, oh, we've missed the bus?
So many times, because actually these are all cases which we have been dealing with, like preeclampsia, what we say that is missed, because mild, it is one of the very, very common, because preeclampsia, it is 50% of incidence. And if we don't admit and we don't evaluate, and patient goes on into the complicating. So what we teach actually, which is most common and which should be evaluated. So we all encounter such situation that patient should have been come before, and it is now, because in today's setup we must have the ICU backup. So we also sometimes send the patient to again ICU backup if they can afford to corporate, if they cannot afford to public health facility. But our ways to lead the professional organization, that first of all we should discuss more common, and we should discuss which is affordable and doable to all settings. So every panelist said that it is CBC, be alert when it is a slight derangement, and always teaching what is new coming up. This is also because it is changing demography. People get IVF anywhere, and they come back to us, and we are having so many placenta related complications. They are higher risk, they are comorbidity. So this is very important, that the third thing, what is new suddenly coming up, patient, people are not aware that scar pregnancy diagnosed as a missed abortion, and everybody can do DNC. So this is a constant teaching, but the doable thing, what is more common, what can be done by each and everyone, that should be our focus. Because I'm really troubled about this massive transfusion protocol. Everybody will say out of fear that they are not doing it, but out of fear they will say, no, 1:1:1. And even there is a question mark, because it is much more for the trauma patient actually. Again, so this is a constant teaching and reaching, connecting to our colleagues. This is what I will say, Manyata, that we should not disregard या patient के सामने कहना अरे ये नहीं किया, this that. We should have respect, and we should do feedback to them that yes, you could have done this, and like we can say feedback report that this could have been done and it could be. And I think Dr. Hema, once upon again in our all academic meeting, we should invite them. Like you remember when we did North Zone UFOXY, we invited rural paramedical officers,
Yes.
nurses in the thing. So when we are investing so much money and they are not part of our academic conference.
Yes, ma'am.
So this is a all inclusion with open heart, with generous heart. It is not like pushing ourselves as a very like expert or something, but we should be very compassionate, not only to people, but also our colleagues also. So
Ma'am, 3 months back, I had Manyata and my staff, and there is a tremendous change in now their attitude, their management, and to deal with the patient. There is lot of difference.
So Dr. Hema will be
True,
so happy to say, because we are all like Dr. Hema leadership, and what we say that Dr. Hema's like now being Dr. Hema in life, it has changed like our perspective totally, and we must be very happy.
I think with all the champions put together, each one simple step has made a giant leap. That's what I'm so delighted about. As how I speak, I'm getting goose pimples, because it's really true that the experience that I've had with people who are so passionate, so committed, they're always wanting to do it, really charges me up like anything, and I'm inspired to do more just because of all of you. Now, final word of thanks by our backbone from artist, Sheetal.
Thanks a lot, ma'am. It was really practical and panel discussion, informative panel discussion across India and Bangladesh. What are the practical situations and how to handle it? Thanks a lot, Dr. Sadhana Gupta, and all the panelists for moderating. It's such a wonderful panel, actually. On behalf of Team Artist, I would like to take this opportunity to thank all our faculty. Thank you, Dr. Lakshmi Shrikande, for all those practical inputs on improving the hemoglobin. And thank you, Hema ma'am, for giving all your inputs. Thanks to our panel discussion team, Dr. Sadhana Gupta, and all the panelists, Dr. Anita Sabrawal, Dr. Asha Nervi, Dr. Devang Patel, Dr. Himali Sinha, Dr. Poonam Goyal, Dr. Saiba Akhtar. And yes, I would like to thank all our collaborators, IHW Council, WCA, WWW, and
when it comes to Emcure, Sheetal is frozen. That's what Abhijit said. Dr. Rita and Purni, have silently always worked behind the scenes, and so has Dr. Divakar. So on my personal behalf, I would like to really appreciate their everlasting support.
Ma'am, I was there. I got cut in between or something.
Yes, you froze when you said you were going to say Emcure, perhaps.
Okay. Yes, and yes, our team, Dr. Rita Singh, Dr. Purni Narayan, and Dr. G.V. Divakar, who are actually still backbones of the artist, I can say. And Hema ma'am has already thanked them, and all the delegates for supporting this event and making this successful. That's more important. And yes, ma'am, finally, a big thank you to you to bringing all the stakeholders together from all the areas, everyone together. And yes, finally, Sheetal Joshi from Team Artist, I'll sign off for today with the promise that we'll again meet next 9th of next month.
Sheetal,
topic. Yes, stay tuned. Yeah.
Sheetal, just give me a chance to say thanks to Hema and Sadhana and everyone. And thank you for inviting me. So I got a chance to meet my friends, old friends, after a long time. It's a great pleasure. I don't know whether Lakshmi is here or not. She's a good friend of me for a long time, Hema, Sadhana. So thank you so much for inviting me.
Cyber never says no.
Thank you.
Cyber, you never say no. We know that, and then we catch hold of you every time.
Thank you so much.
Good. So this was such a fine mix of very fine people who gave their own perspectives very honestly and very elaborately. I must really cap this up with a very, very big heartfelt thank you. Namaskar, everyone.
Thank you so much.
Thanks.
Thank you so much.
Thank you, everyone.
Thank you.
Thank you.
Bye for now.
Bye.
Good
Bye.
job. All the
Bye.
best.
Thank you.
Bye. Good night.
Bye, everyone.
All panelists,
everyone.
and Sheetal, I didn't read chat that 10 minutes, Sarita. I think I took 20 minutes because I was not reading
No,
chat.
no problem.
No, it was going in a very
It's an
good
interesting
flow.
topic, yeah.
Yeah, it was going a very, very good flow. So, abhi tak बैठते हैं जो लोग, they were still, because otherwise we can see many dropouts. That was not happening. So we said, let it be, another 10 minutes extra invested on this is so worthwhile.
Yes.
Thank you. Thank you.
All the best, Sadhana
Abhijit.
ma'am. All the best.
Abhijit,
you.
thanks
All the
a
best.
lot for all the
Sadhana, all the
coordination and
best
support,
for you.
Abhijit.
Welcome, ma'am. Welcome.
Thank you.
Abhijit
All
and Nishad and
stay
Sheila.
connected. All remain stay connected, please.
Thank you. Thank you.
Absolutely. Absolutely.
Thank you,
Thank you.
Dr. Hema.
Bye for now.
Bye.
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 Bye. Thank
Take
you.
care, ma'am.
Bye.
Good night.
Thank you. Bye.
Good night. Bye.
Nishad, you can